Okay, and it's just to say that this webinar will be recorded. We do record these and we share them for anybody who can't make the session. So hopefully this is something that's welcomed by all. But again, as your cameras are off, we won't be recording anybody who doesn't have their cameras on, so don't worry about that. And then again, if you want to listen to it again and share it with colleagues, you can do so after the session. Okay, next slide, please. So today, as with all of our resilience webinars that we've been running, the purpose has remained consistent really throughout these 11 webinars. And it's really just to share the learning that is out there in the system. You know, it's the role of Healthcare Improvement Scotland to kind of bring together that learning and make sure that we're sharing it throughout the country so that people can lovingly lift, as we like to say. It's not stealing or copying, it's lovingly lifting ideas across the system that might apply to your own context. So the topic of multidisciplinary team working was selected through your suggestions, and we do get all of our ideas for our sessions through our links with yourselves and other people that we link with. So please do put anything in the chat that you think that would be good for a future webinar as well. So this is going to be session 1. We are planning on having another session around multidisciplinary team working, because I think we could probably talk about it forever and ever. There's so many members of the MDT and so much going on that we can reflect. And it's such an important topic around collaboration, around increasing access, and of course staff well-being as well. So next slide, please. So we do only have an hour today. As I said, I think we could fill up plenty of hours with this topic, but we are going to showcase a small example of good examples of MDT working. But again, as I said, there will be a future webinar on MDT working again, and so we'll look forward to that as well, because we really can't reflect everything in an hour. So we also hope that the information that's being shared by our speakers is transferable to other settings. So whilst you might be hearing something from an occupational therapy point of view, it might be transferable as well to other settings or other disciplines. So please be thinking about that while you're listening. So as I said, we're always looking for suggestions. So if you have any suggestions of other topics, please do pop it in the chat box or email us after the session, and we'll give you our details at the end. So I'm going to hand over to our first chair of the session, and that's Michelle Watts, who's on camera just now. Thanks, Michelle.
Hi, everybody. It's so great to see you all to what's going to be a really fast-paced hour. So my name is Michelle Watts, GP, Senior Medical Advisor into Scottish Government, and I'm going to chair today's session along with my colleague, Scott Jamieson. So today's session is all about multidisciplinary team working in primary care. And what does that mean at a time when we've got so much change happening? For me, it means 5 key things around time. It means time to see patients, to do what you need to do your job to the best of your ability as a professional. But you need time to plan, to make sure that the admin, that the work around what you do is factored into your everyday. You need time to team, to come together as a team and understand what working in your environment means for you. But you need time to lead as well. And most importantly, you need time to learn, both as an individual and as part of a wider team. So there's a huge amount to think about, and I wonder if these might be helpful for you to think about from a personal perspective on how these 5 T's might apply to you as we hear from our speakers today. There's no doubt about it, multidisciplinary teams are expanding across primary care at the moment at a rapid speed of knots. We've currently got probably more than 4 whole-time equivalents per general practice team working across Scotland just now. And when we factor in the additional work that goes on outside the GP contract, that gets closer to 5. But does that always feel like that for you in practice? And where are all these teams and networks and connections that you might not otherwise be seeing as we get so busy getting on with the change? So today's meeting is really, really important to think about how we look after each other in a multidisciplinary team, because I reckon that if we do that, it'll be better for you as an individual, better for the people you work with, and also better for the patients whom we serve. So without further ado, we've got some fantastic speakers today who are going to show you live around what some of that means for them. So in our first session, I'm going to introduce Claire McManus, our policy and contract lead for this in Scottish Government, and our professional support through Helen Moores-Poole, Cathy Kenmure and Duncan McNabb, who are going to give us some work and issues going on from a professional lens around allied health professions, nursing and pharmacy. So Claire, over to you. Please pass on in the chat, everybody, and I'll see you in a moment. Thank you.
Thanks, Michelle. Good afternoon, everyone. I am the team lead in the General Practice Policy Division in Scottish Government, responsible for the GP contract implementation. And I've been asked to set out a bit of an overview of the background to the GP contract and recruitment of multidisciplinary teams, and an update on progress on where we are. So next slide, please. So I'm not going to go into slide in too much detail. It's quite self-explanatory, but just to emphasise that the 2018 GP contract was a joint agreement between Scottish Government and the British Medical Association, the Scottish General Practitioners Committee of that body, and it represents a landmark reform for primary care in Scotland. And there's a number of elements covered in the contract, but a key focus was on the recruitment of multidisciplinary teams. And that's across the 6 services identified on the slide. And that is about the recruitment of additional clinical and non-clinical staff, ultimately with the aim of better patient care. And next slide, please. And so the better patient care element comes sort of crystallise around 2 key supporting sub-aims, and that is recruiting additional multidisciplinary staff to allow GPs to reduce GP workload and allow them to focus on the job that they train to do as expert medical generalists, and ultimately to treat patients with more complex needs. But also envisages general practice being at the heart of the healthcare system, where multidisciplinary teams come together to provide a wider range of expertise and wider services for patients, and to better meet patient population need. Next slide, please. So how have we gone about doing this? Well, we wanted to put a sustainable and permanent framework in place to achieve these transformation reforms, and that covers around 3 key pillars. So there's the funding element, 170 million per annum is guaranteed from 22-23 onwards. There is the governance element, and that entails having collaboration at both national and local level. And so the implementation of the contract is underpinned by memorandums of understanding jointly agreed by integration authorities, health boards, SGPC and Scottish Government. And these parties all sit on our National Oversight Group, which meets regularly to scrutinise implementation progress. And at the local level, each IA has a primary care improvement plan developed collaboratively, and that sets out how the contract will be implemented locally, informed by the guidance set out in the contract and the associated MOUs. We also have regulations which have been amended to include permanent support for the services identified from 22-23 onwards. Next slide, please. As noted, the collaboration at the national level is broadly mirrored at the local level through the development and implementation of primary care improvement plans. And so the kind of focus is really for between IAs, health boards and GP representatives developing collaboratively the primary care improvement plans, which will develop an effective MDT model meeting local population healthcare needs. In particular, the MOU recognises the role of IAs as planners and commissioners of primary care services and the service redesign envisaged under the contract, and boards have a key role to play in service delivery, as well as NHS staff, employers and parties to the General Medical Service contract. And through the primary care improvement plans, there's twice yearly reporting to Scottish Government on the progress, which also informs that discussion at National Oversight Group. Next slide, please. So what progress have we made? So Michelle touched on earlier, We have now over 3,220 whole-time equivalent MDT staff recruited in support of general practice by March 2022, and we expect this number to increase further when we update this statistical publication in June, July this year. And as you can see from the table, quite large numbers across the pharmacotherapy, vaccinations, and community treatment and care services, and strong numbers across the other services as well. And this equates to more than 3 whole-time equivalent additional MDT staff per average practice in Scotland. And again, we expect that to increase further to in the year ahead as we, over the 2022-23 years, we get those stats published. Next slide, please. In terms of access levels, this slide sets out where we are against each of the services in terms of the practices that have access to these services. And as you can see from the slide, the vast majority of practices have at least partial access to NHS board provided pharmacotherapy services, with more than 90% of practices with full or partial access to level 1 and 2 services. Around 50 to 60% of practices have full access for most of the CTAC services. And for vaccinations, the rollout is quite well advanced, and full or partial access across all of the categories is sitting at more than 80%. Next slide, please. In terms of multidisciplinary working and how we are tracking the coordination and cohesion of multidisciplinary working itself, there, as you can see from the previous metrics, we don't have a specific metric for that. Most of the feedback we're getting at the moment on that is qualitative, but we are also looking at ways to have more systematic understanding of the impact of multidisciplinary working, including through surveys of the GP and MDT teams. But this, we do get qualitative feedback through the trackers and through ongoing engagement with IAs, and this slide gives a summary of some of the opportunities and some of the challenges around multidisciplinary team working, and I think Kathy and Helen are going to come on to that, so I will allow them to go into that in more detail, and I'll carry on with the monitoring evaluation work. Next slide, please. This slide just highlights that the trackers that I've talked about and the statistics that we collect at the national level are, it's a key vehicle for us understanding implementation progress, but it's not the only one at the national or indeed at the local level. And there are a number of other routes and measures that we use to understand the implementation to date and the impact of multidisciplinary team working. I just want to touch on one of these briefly, the local evaluation findings that Public Health Scotland have been supporting on. So Public Health Scotland have been working with local evaluators through our primary care evaluators network to coordinate and synthesise some local evaluation work. And I'm not going to go into some of the findings here, but I've included some illustrative examples at the back of the slide pack, which can be shared with you later. And I think the key takeaways are really that there is local evidence that MDT resources may be making a positive difference in general practice. For example, there is some evidence of reduced healthcare utilisation, positive patient outcomes, and engagement with disadvantaged groups. It is important to note that there are some caveats with the findings from the local scale data, and caution should be taken when discussing these more widely, and there are some gaps that remain, but I think it is evidence that there is some evidence that the MDT is making a positive impact, and we want to continue to tackle those data gaps. Next slide, please. And I think this slide actually just covers what I've just outlined. And then the next slide. Finally, just building on, as I've highlighted, there's a range of monitoring and evaluation activity across the local and national space underway, and we want to continue to build on that to ensure we're understanding the impacts of the reform on patient, staff, and the healthcare system. And these are these sort of 5 boxes highlight the number of ways we want to do that. So there's the developing the national evidence base for primary care outcomes, touched on in one of the previous slides. The health and care experience survey is one way that we understand patient experiences at the national level, when we want to make sure that the multidisciplinary team working is reflected in that. We want to continue to improve the PCIP reporting, and we have done some pilot work recently on getting some more granular data on activity and capacity through that, and we're continuing to refine that in the next iteration of the trackers, which are due to issue imminently. But we also longer term want to mainstream some of the data collection into other existing data collections where possible, to minimise administrative burden going forward, and to make sure it's part of our core data sets and data collection. The Public Health Scotland and Primary Care Evaluators Network I've talked about, but we continue to work with PHS and with that group who are invaluable in terms of feeding back on the local evaluation underway, and indeed looking to prioritise and coordinate approaches to build up that work across more areas in Scotland, to really dig into some of the outcomes of the work, which it has is not currently focused on through the PCIP trackers. And then just lastly, we are looking to do a cost-benefit analysis of the MDT model, which we due to be published imminently by colleagues in HIS who are leading on that, and so look out for that. And then just continue to work on the data caps through a qualitative follow-up with the HSCP's IAs, which we'll be taking forward over the coming months, and then ongoing discussions such as this one. And next slide, please. Yeah, and that just really sums up the next step. Sorry, I've gone a bit over, but really looking to continue to build the evidence base, and bake in the progress we've already made and ensure the long-term sustainability of the programme, and also look to the future. Thank you.
Brilliant. Thanks, Claire. Without further ado, I'm going to welcome in Helen and Kathy.
Thank you, Michelle. I'll wait till the slides come up. So my name's Helen Moss-Poole, and I'm the AHP advisor for primary care and for Chief Nursing Officer Directorate. And I've got Kathy with me as well. Do you want to say hello, Kathy?
Hi. Hi, Kathy Cameron here from Primary Care. Thank you.
So the quote on the first page actually comes from an AHP colleague, and I think it really reflects the reality that we can't just put people in a shared space and then expect an MDT to automatically form. So if we could have the first slide, please. So we asked some of our, sorry, next slide, please. So we asked some of our physiotherapists and occupational therapists who were already working in general practice, from their experience, what helped them to integrate as new members of the MDT, and what they would recommend to other professional colleagues, or to some of the paramedics, to the dietitians, to the pharmacists, to the CTAC staff, or to any new person now entering general practice. What would help them settle in? And really interesting, when they gave me the answers, they fell into kind of 4 main categories, which I've got on the screen. So interconnectivity, all about that mutual effort to integrate, being able to link into the life of the practice, to be informed, to be able to learn and develop together. Another key theme was accessibility, having open doors, having opportunity to discuss cases, being able to liaise with general practice colleagues and have those clinical discussions. Well-being was really important to them. So just the simple things that making us all feel part of a team. So opportunities to share a cup of coffee, to say hello, kind of feeling included, and knowing who to turn to as well, and who was available when you needed that wee bit of support. And then lastly, but absolutely not least, some of that practical support as well. So they talked about the value of having people there to support them with onboarding and IT help when they need it, real clarity about what they do and what they don't do, and each other's roles, and understanding each other's roles, and also some things in the physical environment that helped them as well. So really interesting. But the key messages that came out of it were very much that, both parties, the ones who are already within the environment and the ones that are coming into the environment, they have to really want to make the MDT work and to meet halfway. So we can have the next slide, please. Kathy's going to talk to us about kind of what works and how to build a team, because we do have a growing body of evidence about what works in terms of a successful MDT.
Thanks. Can we move to the next slide, please? Great, thank you. So let's get to the nitty-gritty. Team working, according to Michael West, has some fundamental pieces to it. Small number of meaningful objectives, a set of compelling objectives that your team members share responsibility and accountability for achieving helps create a sense of shared purpose, trust, and collective achievement. Teams should have clear roles and responsibilities which are visible to team members, and that means that team members need to be clear about what activities need to be undertaken, who's responsible for completing them, so that nothing slips through the gaps. And this is especially important when teams are forming, but roles and responsibilities may shift as your team matures and you get to know each other's strengths. So these roles and responsibilities should be revisited regularly to ensure that expectations about how things work are indeed how they are working. and reflecting on how team is working together is a cornerstone piece. So all teams benefit from taking time out to reflect on how they're working together and how they might improve. You might want to do this in the form of team timeouts, away days, or regular huddles, sort of covering both technical aspects of work, but also importantly, how people are feeling. This time will not be allocated to patient care. It may feel wasted to some. However, I think it's really important that people feel able to contribute freely, regardless of their role or position in the management hierarchy. So it's important to think about how you will create that safe environment for your colleagues to speak up. Next slide, please. Thank you. Recent studies by Michael West, and he's a key clinician researcher that has got a huge amount of evidence. And his research shows that including those in training have shown that well-being, flourishing and work engagement of health and social care staff is affected by 8 key factors, and they're listed here. And they can be organised into the 3 core needs. So meeting people's core needs at work is important in supporting their well-being and motivation, and compassionate leaders constantly strive to understand and meet the core needs of people in which they work. And I think this is demonstrated when I asked some nurses working within general practice what they felt were their pieces, and a few quotes suggested. So I've gradually expanded my practice within the support of the GP colleagues and now feel comfortable with assessing the majority of patients presenting, passing on to a GP member of the multidisciplinary team if appropriate. So I really enjoy my role and find it incredibly satisfying. I've had some patients who come in want to see a doctor, but they're happy once they realise what I can do. And I get positive feedback from patients and from those that I work with. Another one said, I have incredibly supportive GP colleagues who encourage me to develop my skills and experience, but are always available for help and support if needed. I also have a good working relationship with my GP and colleagues, and we learn from each other, especially as I do not have a GP background. Supporting each other in different roles, essential to me. I am the first A&P in my practice, and it was my first A&P post. So between us, we worked out what my role would be, and I felt they trusted me to develop the role and take it forward. So there's another example around trust. A last one said, our service provides time, compassion and understanding, identifying training needs for staff to support patients to be cared for within their chosen setting. So that person demonstrates that compassionate leadership. So if we look further afield, the Health and Care Select Committee down in England recently conducted an inquiry on workforce and burnout and resilience in the NHS, and it concluded that burnout is widespread reality in today's NHS, and that will be no different where we are, and has negative consequences for the mental health of individual staff, which has an impact on the colleagues and the people that they care for. That can be offset with compassionate leadership, and it must be at the heart of local, regional and national efforts to nurture cultures to provide high quality, continually improving and compassionate care for people in their communities. And given the increasing complexity of delivering that health and care, it's vital that our leaders place a high priority of supporting the health and well-being for people at work. I'm going to pass over to Helen now, who will build on that piece.
So we can have the next slide, please. So time kind of prohibits us for going into kind of any of these in any detail, but we wanted to give you some links and resources so you could go away and continue your learning. I'm a real big fan of evidence-based practice, but also of us building our own practice-based evidence. So that first link is a really nice link to a presentation given by an expanded practice team in Forth Valley during the NHS Scotland conference last year. On the slide, you'll also see a link to a really useful resource, which is published by the Royal College of GPs in Wales and the Royal Pharmaceutical Society. That is a little booklet full cram-packed of really helpful advice about establishing core values and behaviours to help your team. Really handy little thing. And then there's also some links in there to some recent research by Natalie Jones, a clinical academic, an occupational therapist working in Sheffield, and those all really well worth a link. There's a wee video as well if you'd rather watch that with a cup of tea. And then the final slide, we've also got some really nice professional resources as well. So the various different professional bodies have also got some nice implementation guides, materials for receptionists, materials for GPs to put on their websites. So lots of information there. And certainly we also have national groups for each of the AHPs involved, and also for general practice nursing, general practice managers, as you'll know, and they again continue to cascade and build resources. Thank you.
Brilliant. Thanks, Helen. I told you this would be a rapid lunchtime session, so I'm going to hand over to Duncan now.
Thanks, Michelle. Hello, everybody. My name is Duncan McNabb. I'm a GP down in Irvine, and I also work for NES as one of the GP assistant directors, where I work in patient safety and quality improvement. I'm going to be talking today about work I did for my PhD, which looked at pharmacists working in GP practices and really how you can optimize their impact. Next slide, please. But before I talk about pharmacists, I'm actually going to talk about NASA. So NASA had a very famous policy where they urged everybody to work faster, better, and cheaper. Now, a lot of people have written about this and blamed this for some of the disasters that they've experienced. Then what they say is that you can work faster and better, but if you do, you won't be cheaper, or you can work faster and cheaper, but if you do, you won't be better, or you can be better and cheaper, and then you won't be faster. So these are competing goals or competing priorities. And that was a key finding really from my PhD, is that how do pharmacists balance the different competing priorities that they have? Next slide, please. Because pharmacists were introduced, as we've already heard, part of why they were introduced was to reduce GP workload to free up time for more complex cases, but also to increase aspects of quality such as safety and effectiveness, and also to save money. The problem is that you could maximize the impact in any one of these, but it's very difficult. If you maximize impact in reducing GP workload, you're not going to increase quality as much or save money as much. So again, these are competing goals, and it's about how you balance them. Next slide, please. So when I looked at the impact of pharmacists working in GP practices, there's plenty of evidence to show that they can increase the safety and the effectiveness of medications prescribed. Interestingly, some of the actions they do to increase that can actually have a negative effect on GP workload. So increasing safety and checks and things like that could increase GP workload. But interesting, another thing that seemed to promote actually was well-being, which Michelle mentioned earlier in the talk, the GP well-being too. Obviously it does take work off GPs, but some of the things can have a negative impact on that. Can we go to the next slide? So I wanted to see where it was working well, why it was working well there. Okay, so everywhere I went, it was clear that pharmacists were thought to be very thorough. But where it worked really well, they balanced this with efficiency. So this is a very famous thing called the efficiency thoroughness trade-off that we all experience every day. The GPs in the audience have come in inside a 2-inch thick pile of prescriptions. The efficient action is to sign them all. The thorough action is probably to look up the notes of them all, to phone up half of them, and to see a quarter of them as well. But you don't have time to do that, so you need to value efficiency in these aspects more than thoroughness. Pharmacists were brilliant at anticipating the risk of actions that they did, but where it worked really well, they also anticipated impact on workload. So they could do differences. So if they're not issuing a prescription, what they would think, they think, well, I know this situation and it's likely to come back to the duty doctor at 5 o'clock on a Friday. So what I'm going to do, I'm going to work a wee bit differently here, and I'm going to phone the patient or the nursing home or the pharmacy and sort this out, or leave specific instructions for admin staff of how to deal with it. So they anticipated that workload. And then that bottom part there, they were able to adapt how they worked. So they would change how they worked. They would go between being thorough and efficient when dependent on the conditions that they found. But they took responsibility for their actions. They had shared values and shared goals with the practice. And that meant that they all kind of worked in the same manner. So they knew in this, if you like, spectrum of thoroughness to efficiency, there was an agreement of where they would sit within the practice if they wanted them to be super thorough or super efficient. But they also had this thing that I've termed system understanding, that they understood the decisions they had to make from different perspectives. So they didn't think of it as a single task, they thought of it as part of the wider system, and they understood the impact that would have on other people in the system. Can we go to the next slide, please? So some of the things that helped, and I see this in the chat already, is talking about co-location. So co-location was key, even if it was only for a bit of the week. And for pharmacists, it was actually really useful being co-located beside admin staff to understand that perspective of the patient's contact in the practice. We've seen there in Helen and Kathy's stuff about agreed roles and responsibilities, but it's probably more than that. It's about agreed goals. What are the goals of this person going in here? What are the values of them that they're trying to do? And that has to be agreed and be explicit between the pharmacist, the practice, and the employer. And one of the practices within, they employed their own pharmacist, and that was much easiest model to get agreement within what their values and their goals of their work were. People have put in the chat about induction, and that's been mentioned, and that's key to learn roles and to learn about decisions in the system from different perspectives. And mentoring's been mentioned as well. And mentoring's key. It's not training. Training to complete a task is a completely different thing. This is about mentoring, about how do you adapt what you're doing based on different conditions that you'll experience. And of key importance is what's the impact of that adaptation. And to do that, you need this system understanding. So you're not just thinking about a task, you're not thinking about meds rec or a special request. You're thinking, how does that fit in with all the different perspectives on how we're working? So we've mentioned responsibility, agreed goals. I've also mentioned about this balancing efficiency and thoroughness. And a key here is quite difficult for some people to agree, but in a complex system like medicine, it's impossible to be maximally safe and maximally efficient, and that needs to be explicit and agreed. And again, as well as thinking about risk, we've got to think about workload. And one thing that seemed to help is actually not being over specifying how people work. Allowing a bit of variability in how people work actually allowed them to get the best out of them. If we over specified protocols, it often restrained them. And so I've said here about minimal specification to allow local adaptation, to allow them to adapt how they're working, to try and balance care between these different priorities that they have. So that is a whistle-stop tour of many years of work, but I'll stop there, Michelle, and let you go on with the rest of it.
Brilliant. Thanks, Duncan, and all of our other speakers. Huge amount of information in these slides, and they will be shared, and tons of brilliant stuff coming in the chat box. We don't have much time for any chat, so what I'm going to suggest we do is we just pass straight on to Scott and introduce the next bit. Grab a quick gulp of tea, folks, and buckle in for round 2. Fantastic stuff coming out. Thanks, Scott.
Thanks so much, Michelle. Scott Jameson, everyone, GP up in Kirriemuir and Tayside, and here to introduce the second half on behalf of RCGP Scotland. We have 3 speakers who will hand over to each other, one to the other. Big thanks to Judith Cairn, the Improvement Advisor from NHS Lanarkshire, who stepped in last minute to tell us about the exciting work on occupational therapists in general practice. You might have seen it on social media. It has been popular. Andrea Davidson follows, who is a practice nurse, as I recall, in Forth Valley, talking about those expanding roles of nursing within general practice, and handing on thereafter to Denise Mellon, practice manager within Ayrshire and Arran, and talking about care navigation, one of my favourite subjects in general practice, very key aspect for us all, back to the Starfield principles, and general practice being that contact place for working out where to go. Starting off with Judith. Straight in, Judith, if you're happy to take us on, and thank you so much again for stepping in last minute. Unexpected circumstances, but great to hear from you today.
Thank you, Scott. Delighted to be reminded that I'm an honorary member of the occupational therapy team in Lanarkshire, so pleased to step in, but no, I will not do as much justice to these slides. Next slide, please, as Shauna would have done, who wishes she could be here. We thought it would be really helpful for us on the next slide that will just be popping up in a moment to talk through the timeline and how I became involved, and the piece of work that we're going to talk about in terms of multidisciplinary working. So it goes right back to the previous fund, which was the Primary Care Mental Health Fund, where we were fortunate enough to test the idea of advanced practice or occupational therapists working in a GP practice to see would that be a successful component of a multidisciplinary team. It evaluated exceptionally well, but it's been a long journey to get to today. We were then able to expand through, and at that point we started to talk about skill mix. The reality was we wanted to test whether it was the 2 great people who we had working with us, or if it was actually occupational therapy that was making the difference. And with the reality of space in terms of GP practices physically and the financial ability to keep recruiting at a band 7, we looked at skill mix as well. And we kept testing and we kept exploring how that would best work as we went through. We have consolidated to a model now that is a hub which is co-aligned with practices, and I'll talk a little bit more about what that means for multidisciplinary working at some point in this quick time that I've got with you. And then we are now at the exciting time of utilising the technology that's there in terms of Vision Anywhere and being able to do that. So next slide. On the next slide that you'll see here, I think the important bit that I would like to highlight is the third tick, which is the ease to access and how that links to multidisciplinary working, that it's working across the teams and making sure that the journeys are as simple for patients to get to the services that they need. And that's been critical to us. Most of you will have heard about the Occupational Therapy Project, so I'm not going to talk too much about that, but I do think it's important just to remind ourselves on the next slide what we've actually managed to achieve. What we've managed to achieve for patients, it has been incredible. The patient stories that we get through, and it just shows us the difference that we are making. What we've managed to achieve for GPs has been evaluated, and we do get feedback from our GP colleagues, and we have seen that we have made a positive impact in terms of their workload and stress. People ask us, when am I getting my occupational therapist within my team? So that's always a good sign. The service mix model and the skills have shown us a better way of working across all the other members of the team, and not seeing that one person takes a patient and that it needs to loop back to the GP. That's been really critical for us to try and get that right, and we still work on that day in, day out. The next slide that we're going to move on to, that to me is what we get asked time and time again, the how. So I think I just need to be honest here. We grabbed the opportunity that the Primary Care Improvement Plan offered us. We listened carefully to the occupational therapists about what they believed and their belief about how they could be a member of the multidisciplinary team. We took the learning and the testing and we built on that. And it all came down to partnership working. They worked with us in our team, and they still are working alongside us, having quality improvement support. But from the very beginning, we worked with GPs. We listened really carefully to what GPs wanted and how they wanted to have occupational therapy working in their practices. It was all to do with communication and building that relationship from day one. Shauna was a known face from the beginning, and really anywhere you went, you would be hearing about what occupational therapy was doing. If we move on to the next slide. I probably could do the whole hour session on quality improvement. It is my bag, but it is the one thing that we believe made a difference. And I'm saying we because I'm an honorary member of the occupational therapy team, as I talked to you just now. What I've heard from our occupational therapy colleagues is that they have been involved in many pilots before, but without quality improvement. And the difference this made was that they were able to show the impact, demonstrate the change, adapt as they went along, and change the model to be what it needed to be, listening carefully to the members of the GP practice team and indeed other members of the multidisciplinary team. We were able to show the financial impact that we were having and the savings that we were making to the wider health and social care system. And we were able to show that the skill mix model was effective and sustainable. And to us, that's what made us successful in being able to go forward with where we are today. If we can move on to the next slide. So how did we achieve it? It was all about relationships. It was all about talking. It was about sharing the journey. We made sure that the role was fully understood at a GP practice level across the whole team. It was just common and normal practice to be saying hello in the morning, talking to members of the GP practice team, working in with the rest of the multidisciplinary team, having coffee, having the chats. And if something came through the occupational therapy team that wasn't maybe best placed, not just saying no and sending back, but having a conversation and talking and working out what the best thing was for that patient. We made sure that the impact was fully understood for everybody. So the GP practice teams, all the impact on their time and the time that they were saving. And it was really important for us to get to that. So if we move on to the next slide. So where are we now? We are in an incredible position that we are now going from 2 staff way back in 2017, working across 2 localities to now 10 localities. We're finishing our final section of recruitment, hopefully, and we're prepared and we're ready to get things settled in as we need to. And we will continue to use our learning to continue to grow our way of working within a multidisciplinary team. Hopefully that's covered everything that I need to cover. Apologies that you didn't have Shaunad, but I will now pass on to Andrea.
Thanks for that, Judith. My name's Andrea Davidson. I'm a practice nurse in NHS Forth Valley. I'll use the term GPN for short throughout my presentation. I moved into primary care very quickly after qualifying and have been district nursing initially from 1996 and moved into my first general practice nurse post in 2008. Next slide, please. So here I am today, minus a paper hat, thankfully, and after 32 years of nursing in my role as a lead general practice nurse and very much working at that level 7 with advanced skills as described in the Transforming Nursing Roles paper 6. Doing this presentation has really made me appreciate how far the role of the GPN has evolved from the very early days in the late 80s when the role was first introduced. It's also made me reflect on my own personal development within the role and the opportunities that have arisen because of that. When I started as a GPN, QOF was very much still in place, and whilst it did bring a bit of structure to the GPN, it wasn't very patient-centred. It focused on tasks and box ticking and not necessarily what the patient wanted to address, and it didn't really encourage an individualised approach to care. Even coming to general practice nursing much later, I'm not very sure that in my early days I particularly enabled my patients to live well with a long-term condition. Such was my focus on getting those silly boxes ticked. Development of education later on in specific to general practice nursing then enabled GPNs to really develop knowledge and skills and specialist interests in long-term conditions, sexual and reproductive health, etc. And that, along with non-medical prescribing, really saw GPNs starting to take the lead in many areas and assuming responsibility for really a lot of the decision making that was previously done by GPs. Autonomy within the role of the GPN is a huge advancement, and with GPNs really now diagnosing, making complex decisions, referring on to secondary care, and continually striving to provide that high quality, evidence-based and person-centred care. The introduction of the new GMS contract has certainly seen our role change recently with the development of CTAC services, vaccination transformation, etc. However, the breadth of the role is still huge, and from personal experience, the learning never stops, and I see our role as very much being dynamic, preventative and proactive. I've also been very fortunate in my time as a GPN to have the opportunity to take on other roles such as education advisor with NES and 5 years ago as lead for general practice nursing within my own board. Both of these roles have enabled me to build on leadership skills whilst developing myself and others to be involved in work and projects I would never have imagined being part of. As well as developing in leadership roles, many GPNs have completed additional education at advanced practice level, such as advanced clinical assessment. And some, like myself, have simply done this to enhance their current role as a GPN, but others have gone on to provide that dual or hybrid role of GPN and ANP, which not only enables them to manage the acute episode of care, but also address longer-term needs for their patients. I hope that gives a little bit of insight into how far the role of the GPN has evolved and expanded, and that with the appropriate education and competencies, there's so much opportunity to develop within the role to become an independent, autonomous practitioner. Next slide, please. So thinking specifically about the multidisciplinary team, I can think of many examples actually of how my role interfaces with the other members of the team, but one particular scenario stands out for me and I'd like to share that with you. My patient was attending for a routine annual review, and it became apparent very, very quickly that she was struggling with low mood. She was tearful, she'd stopped all her medication and was suffering physically as a consequence of this. She'd lost her mother suddenly during the pandemic. She was struggling to come to terms with this and was generally isolated with very little support. With her consent, I was able to book her in to see the specialist mental health nurse within the practice in 2 weeks, and then to see me again 2 weeks later. Although very obviously still having issues, when I saw her again, she was able to speak to me without crying. She was using strategies to help her manage her anxieties and was willing to restart her medications. She also agreed for me to refer her to her community link worker to see if she could be supported in resuming previous activities such as church, etc. She continued to see the specialist mental health nurse, and through this was referred for bereavement counselling. I've seen her since again, and she admits that she's some way to go, but told me without the support of the practice, she isn't sure how she would have coped. She's starting to feel more positive about her future and also physically better now that she's taking her prescribed medication. To me, this is an absolute example of the right care at the right time and 100% in the right place, which is right in the heart of our communities. And really, without this multidisciplinary environment, the pathway I've described would not have been possible for this patient. Her care was responsive and working collaboratively to understand both her physical and her mental health needs allowed us to formulate the right plan for her at that time. And I really hope gave her what she needed to move forward with her life and ultimately improve her health outcomes. Next slide, please. So apologies, the top circle in this slide should read GP, GPN and ANP, and I'm sorry, but for some reason the slide I've sent through hasn't included ANP. So what this slide shows is the patient right at the centre with the ability to link in with different members of the multidisciplinary team, often with overlap and often accessing more than one service at a time. So to finish off, for me, the development and expansion of the multidisciplinary team environment has been a very positive experience. Of course, any change in practice has its challenges and new ways of working take time to bed in, and we know that workforce challenges can impact on these services. However, having direct access within our practices to ANPs, physios, pharmacists, mental health nurses, OTs, I hope in all health boards eventually, has huge benefits for both practice staff and patients. I think moving forward, we need to continue to support each other in these new teams. We need to continue to build on promoting better integration, and simply we need to continue working together to simply be better. Thank you for listening, and I'd like to hand over to Denise Mellon, Practice Manager, Ayrshire and Arran. Thank you.
Thank you, Andrea. I'm Denise Mellon, Practice Manager in Ayr within Ayrshire and Arran. I've been asked to share our experience on the coalface of introducing and developing care navigation, or signposting, whatever you would like to call it, and also what we've learned along the way. In Ayrshire and Arran, our MDT staff have been embedded within the practice premises wherever possible. However, I am aware that there are different models throughout Scotland through local hubs, for example, but I will talk about our experience today. Next slide, please. Some of you might agree with me that educating patients is key to them understanding and accepting change within general practice. The campaign highlighted here supported this. Most of you will recognise this visual poster, which was also commissioned as a TV advert. I'd like to share how we introduced care navigation as a practice, and this started for me with the practice admin team, our gatekeepers, as many patients like to call them. Next slide, please. So around 12 years ago, the doctors that I worked with would complain to me about patients seeing them who could have been better served by the practice nurse, the health visitor, or with a visit to the chemist, as we used to say. So in order to support the doctors and provide assistance to the admin team, I came up with an A to Z of ailments. This list indicated who was best to see the patient. So I suppose it was care navigation on a smaller scale way back then, and also before it had a label. I didn't realise at the time that this would develop over the years, and with the new GP contract include pharmacy, CTAC, physio, mental health and community link practitioners, and of course OTs. I learned over time as signposting evolved that educating the practice team is key to delivering something new. Now, educating your team and training your team does take preparation and time. However, I believe that knowledge is power, and by providing your staff with the tools that they need ensures consistency and also safety in the information that's being delivered to your patients. I think a bit of investment with time allows your staff to navigate with confidence. And a few top tips I would give is to know what you do offer locally. Set a review period with your staff, listen to them, listen to their feedback, and then learn from that. Next slide, please. This slide reflects just a few examples of how I supported our admin staff to deliver care navigation. So firstly, I provided the team just with some simple things like a list of pharmacies who do provide Pharmacy First, and also local opticians who provide daily appointments for eye issues. We also held education sessions over lunchtime with the OTs, our mental health practitioner, CTAC, with the admin team, so that this provided them with information on who to refer in and without the need to ask the doctor or for GP intervention. Through the patient system we use, we're an EMIS practice. We also preset the appointment slot timings for the healthcare professional. They all have different time slots for maybe assessments, reviews, different things. So this ensured that the admin staff didn't have to think about that. These appointment slots are preset to the needs of the different consultation tasks and disciplines across the MDT. And lastly, providing guidance on the correct language to use so that patients understand and feel listened to rather than being spoken to. And I found that was vital. I do find patients don't know what care navigation is, so we have to look at our language and how we sell that to patients. Looking back at the previous slide and this slide, the information that I provided the team with sits above our call centre desks and at reception so that the staff have quick visual access to it. They don't have to be flicking through papers to find the information they need or going onto the desktop to try and establish what they're delivering to patients. Everything's all in front of them, and it just means that the tools have increased staff confidence when signposting. Next slide, please. So looking to our patients, introducing care navigation worked for us by drip feeding the information to the patients through various channels. Some of these channels can be seen on the slide here. And I do have permission from Rachel, our pharmacist, and Claire, our current OT, to share these pictures with you. We also emphasised and advertised the fact that receptionists are no longer receptionists, that they are trained in care navigation and signposting, and they really are patient assistants. They're not just receptionists. So I think that works alongside the whole care navigation. Alongside educating patients about MDT staff, who they are and the services they offer, I found that advertising them as part of the practice team also helped with patient acceptance and engagement. Next slide, please. Developing the team, I feel, can be done quite simply. We have a photo board at the entrance, and this details not only our practice employed staff and the faces that the patients have been used to seeing over the years, but also the new MDT members, who they are and what they do. As we say in Scotland, it's always good to put a face to a name. And I would certainly say that this has gone a long way to reinforce the message that the doctor is supported by many health and social care professionals. Every day, whoever's in the building, MDT staff members are invited to join coffee at 11 o'clock alongside the GPs, and this is hugely valuable to A, inclusion, and B, case discussion, you know, every day as we go through. Next slide, please. So as you can see from the slide, there are many benefits to care navigation. Your staff will feel empowered and more able to help your patients see the best suited person for their needs. Navigating patients to other professionals puts the patient at the centre and also supports your GPs and makes your practice run more efficiently. And if we could just bring up the few challenges, please. If there are any MDT portfolio managers on today's session, I would draw your attention to some of the challenges. The few challenges that I have found since the introduction of MDT working are mentioned here. We find ourselves indirectly managing people that we didn't manage before, and often issues arise like absence and, you know, who's going to cover the work when such and such isn't here. And I would just ask people to pay attention to that. I think it's been a wee bit overlooked. But on the whole, the practice benefits from what has been a positive addition to general practice and to serving our patients in the best way we can. And after all, that's the reason we're all here. So thank you, and I'll hand back to Scott.
Wow, wait, guys, thank you so much to all three of the speakers there, to Denise, Andrea, and to Judith. What a whirlwind tour of some amazing examples of great working, and I'm sure everyone on the call recognises you know, some of those really key themes there, you know, ourselves included, about that collegiate working. I'm so fortunate to work in a kind of town where everybody is kind of based within the health centre, and it makes a massive difference to have those coffees together, to have those informal catch-ups to see how what's going on. It makes a huge difference to the care that we deliver. And some great things in the chat. Fiona, I spotted there in the chat. I didn't see you were here as well, Fiona. It's great to see you, but Fiona Duff and myself sharing the access to general practice review, and there's so many things in there, Fiona. My head's bursting with it, trying to work out exactly how we do this, because there is no doubt that we're not quite getting it cracked. You know, everybody's moving to a new practice and doesn't quite know how to navigate this new place that they're at, and there's just a nice universal way that no matter where you move to in Scotland, you're able to universally access in the same format something that's recognisable to you, to work out how do I do this, both for new patients and for ones moving from practice to practice. So definitely some work in there. I defer to Fiona for her help and expertise at working out how to do that. But hand back to April for closing remarks to finish hopefully as quickly as we can here at 2 o'clock. Thanks, April.
I'm blaming you for this, Scott, because you said before this session we're always on time. So it just leaves to me to say thank you so much to everybody who's contributed, and also a shout out to the RCGP, Scottish Government, and NES, who we produce these series of webinars alongside. Just thank you all so much for your healthy participation in the chat box. We have got an evaluation questionnaire in the chat box. The link is there. We would be very grateful if you could fill that in for us. Let us know what we need to do better, how we can improve. And also just to say, do not worry, the information, the recording of this webinar, the slides of the webinar, and even a collation of the chats and the things that have been shared in the chats will come out to you after this session. So thanks again, everybody, and have a lovely rest of your day. Bye.